Good afternoon, and welcome to the Medical College of Wisconsin's Coffee Conversation with Scientists. Since early in 2021, we've been sharing the science behind today's most important health topics. Coffee Conversations is brought to you by the Advancing a Healthier Wisconsin Endowment, a statewide nonprofit working to improve health and advance health equity in Wisconsin. I'm Dr. Jessica Olson, Assistant Professor in the Institute for Health and Equity at the Medical College of Wisconsin. Today, I am joined by Dr. Adrienne Cobb. Dr. Cobb is a board-certified breast surgical oncologist and assistant professor at the Medical College of Wisconsin. Dr. Cobb has been an active researcher in the field of oncology, and her work has covered a diverse set of subjects in the world of cancer treatment. Much of her research has been focused on postoperative outcomes, studying relationships between patient recovery and factors like hospital volume, race, and ethnicity. Dr. Cobb's research has also covered applications of big data in medicine. This has included the use of machine learning to analyze large data sets, as well as investigations into its potential applications in future healthcare research in the fields of surgical oncology and surgery as a whole. As a surgical oncologist at MCW, her focus in patient care has been centered in breast cancer care. Welcome to Coffee Conversations, Dr. Cobb.
Thanks for having me, Jessica. I'm excited to be here.
We are going to cover a great list of questions regarding the science behind breast cancer. I'm so excited to have you here for it. And I encourage all of you watching to drop any questions you have on the topic into the comments. We will get to as many of those as possible today. So please, if you have questions, we're monitoring the chat, and we are so fortunate to have Dr. Cobb's expertise. Let's get started. One of the first things we wanted to cover, we didn't want to go into, rattling off a lot of facts about breast cancer that people can just, type into a search engine. But there's a lot of information out there when we're looking for information on breast cancer care, treatment, detection, prevention. Where do you recommend that people look when they're trying to educate themselves about breast cancer?
Yeah, I think the internet can certainly be a little bit of the wild, wild west. And so there's a few places that I think have really good, trusted information. This is information that's backed by research or evidence-based. And a few of those places are the NCCN, which stands for National Comprehensive Cancer Network. They make literature both for physicians, doctors, and scientists, but also for patients in a really easy to digest format. There's also the American Cancer Society has a website with lots and lots of different details and links that patients can follow. And then finally, the National Cancer Institute also has a lot of good information. And I like those three because there's a ton of stuff that you can find, but it's not always based in the evidence and it's not always up to date. One of the things about breast cancer care is that it is changing all the time. And so I like those three places for good sources of information.
Yeah, absolutely. Well, and in speaking of, changing all the time, I think we were chatting briefly about how screening guidelines have changed. What are the most up-to-date screening guidelines for people?
Yeah, so there was some back and forth about what age at which women should start screening, but now we've sort of all settled on consensus that women of average risk should start their screening mammograms at age 40. And when I say average risk, I just mean you or me or anyone who doesn't have a history of cancer themselves or have a family member, first degree relative, so that's like your mother, your sister, with cancer. The people who are at a higher risk, or those folks that have family history like I described, should start getting screened a little bit earlier.
Well, and that's when it comes to risk. I don't know about you. I hear a lot of different ideas, beliefs about causes and preventative measures. And one of the most common ones that I think we've both heard is that people don't think that they need a mammogram or they're not high risk because breast cancer doesn't run in their family. So how often is a patient has it, genetically in their family versus has no history? Is that a good way to determine if you're high risk or not?
Yeah, the majority of patients who get breast cancer don't necessarily have a really strong family history or a genetic syndrome. Most of these are what we call de novo or kind of brand new, just that happen in patients. So just because you don't have a family history, like one of those first degree relatives we talked about, doesn't mean that you shouldn't be screened or that you're not at risk. Screening mammograms are one of the great kind of discoveries of science that have allowed us to identify cancers much earlier and provide treatments accordingly.
Absolutely. And what about different causes, different beliefs about things that cause breast cancer? I know I've heard everything from wearing a bra causes breast cancer, certain things in your diet. What do you hear about causes? Are there any things that people tend to attribute to breast cancer risk that don't have any correlation to actually causing breast cancer? Does wearing a bra cause breast cancer?
Yeah, there's like I said, there's lots of stuff out there and different things that get passed down through families, word of mouth, kind of urban legends, if you will. But have wearing a bra certainly does not cause breast cancer. The things that we think, add to risk would be, really heavy alcohol consumption, smoking, being obese, things that we kind of know attribute to a lot of different diseases and a lot of different types of cancers. Of course, if you have a genetic predisposition, like a particular gene or something like that, that puts you at a much higher risk. But for average risk folks, it's really just those kind of lifestyle things, and not necessarily, you having been, wearing a certain type of bra or eating a certain type of cheese or, something, kind of arbitrary in that way.
If you were going to say cheese was a problem, I was going to have a moment. I
Not in
want to,
Wisconsin.
ooh, you know your audience.
Yeah.
There's a question in the chat, and I want to encourage people to keep engaging in the chat because we can see it. So I want to get that question answered right away. Our question in the chat is, I have dense breasts, but haven't been able to get an MRI yet. Are ultrasounds good for looking at a suspected area that we're watching?
Yeah, so oftentimes we use, especially for patients with dense breasts, we use both mammogram and ultrasound to help us get a better picture. So the mammogram may not be able to see through the densities as well, but when paired with ultrasound, it helps us better identify those areas of concern. So that's why we don't really use MRI as routine screening because we know when we combine mammograms and ultrasound, we still do a pretty good job of identifying things that are problematic.
So, and I want to take it back a step just in case people aren't familiar with the difference between, breasts and density. Can I tell on my own if I have dense breasts, or is that something a physician needs to tell me? Is that something you can determine? Anyone can determine, or is that a diagnosis? What is that?
Um, it's not really a formal diagnosis. Oftentimes, patients who, like younger women, tend to have denser breasts just because of the way that the tissue is set up. So patients will come and say, my breasts have always been kind of firm, or they've always been a little bit lumpy, or things like that. And we often attribute that to dense breasts, but they probably don't actually hear the term attached to themselves until maybe they've gotten a mammogram or they've gotten an ultrasound, because it really is sort of a radiologic finding, things that the radiologists see to say, oh, the tissue is dense based on these factors.
So, what is the process? I think it's really scary to think about being diagnosed with breast cancer. I think that is something you encounter in your day to day work is patients living with this diagnosis. What is the process? What do people go through after they get that really scary diagnosis?
Yeah, I think after diagnosis can be kind of a whirlwind for patients, right? They're eager to kind of understand what happens next. The folks that are taking care of them are eager to get the ball rolling so that, we're not losing any time. But essentially, once a patient has, I'll even take a step back. Let's say you're just presenting with a mass. You feel something abnormal, you go to your doctor, you'll get sort of worked up, and that means the imaging. So you'll get a mammogram, probably an ultrasound, and ultimately, probably a biopsy. And that's really how we get the tissue to make your actual diagnosis that says, okay, yes, you have cancer. At that point, you'll see usually a surgeon first. It varies depending on where you are, but usually you'll see a surgeon first. And we talk with you about what your diagnosis means, what type of cancer you have, and we try to lay out for you kind of what the next steps are, whether that is going to surgery first, whether that is saying, you should meet with a medical oncologist because maybe chemotherapy first will be best for you. Maybe, and then letting you'll also meet with a radiation oncologist because radiation may be a part of your treatment plan. It really is just kind of taking it step by step. And I always try to just explain to my patients, like, okay, here's where we are, here's where we're going. here are the things in between to try to keep everything in order because it really is a lot.
And how do you, I mean, you started to say, how you do it and how you navigate it, but you're seeing people on some of the worst days of their life, I imagine. How do you, as a physician, provide that care and support? What's the approach that you take?
Yeah, I try to be really patient, and understand that even though I do this every day and I talk about this every day, that the person who I'm interacting with is hearing many of these words for the first time and may not know what any of them mean, and may not have a point of reference either from a friend or a family member who has been through it, and that people are just outright terrified, to be honest. And even those folks who come with a lot of knowledge, who, I've been on the internet, I know this is what I have, I know these are my treatment options, they're still looking for guidance, and they still want to be heard. And so I think it's really important to kind of ask patients, what do you understand about what's going on with you and what's happening with you right now? And what gaps can I fill?
That sounds like a very compassionate approach. It sounds like just the support that patients need. I'm going to turn to the chat. I've got a list of cool questions, but I do want people taking advantage of this awesome opportunity. There is a participant who wants to know, what are the advantages to breastfeeding and breast health?
So we think that breastfeeding can help lower your risk of breast cancer overall. And not necessarily kind of in a vacuum, but when we think about it in combination with, maintaining a healthy weight, when we look at family history, when we look at, we use a couple of different things like, when you had your first menstrual period, how many babies did you have when you had your first baby? All of those things are pieces of information that we can put into various risk models to help us understand, okay, how much risk are you at for developing breast cancer? So I hesitate to say that, breastfeeding is the end all be all. Ultimately, we want your baby to be fed and healthy. But if you can breastfeed, we certainly think that you should. And it is one of the things that can help lower your risk.
There's a term that I don't know, so I assume you know it. I'm eager to learn what this is. One of the audience members asked, "Would you please discuss thermography?" I've been hearing a lot about that versus mammogram. I'm not familiar with the term at all. Are you familiar with it?
To be completely honest, I'm not. I'm using my context clues, and I'm
Yeah.
guessing it has something to do with maybe a heat map or something like that. But I have to be honest and say I'm not familiar with it, and I don't believe it's something that we do here. But maybe it's something new coming down the pike, but I'm not personally familiar with it.
Sure. And if that audience member would like to provide a little more context in the chat, but that's a new one. That's one I'll be looking up when we're done chatting here. So I want to turn to a different a line of questions and talk about the healthcare setting. I want to talk about what we tend to do really well and what possibly physicians, researchers, healthcare professionals can do. What more can we be doing to improve breast cancer outcomes? Are we doing everything perfect, or is there room to improve?
Yeah. Oh, I think there's always room to improve. I think that, when we think about breast cancer in the world as a whole, I think there's been so much good moves made in terms of research dollars and things that are, happening that are developing new treatments and making those treatments available to patients. But I think in the day to day, we still have a lot of work to do. I think there are patients who still face a lot of systemic barriers to getting the care that they need, and being able to do so, fairly easily. And I mean, I use easy, easy is a relative term for sure, but, it's a lot easier to participate in your care plan if you don't have to, go through an obstacle course first to get there. So I think some of the things that we can continue to focus on are kind of hospital and systemic factors that, can be barriers for patients, whether that's trying to group appointments or trying to provide transportation or providing new patient coordinators or navigation to help patients really go through this process with a sense of education and a sense of ownership in their care plan, and not that they just like kind of going along, not really understanding what's happening to them because it can be very overwhelming. So I think we're doing a lot of good things, but for sure we have room to improve.
Yeah, I can't help but think, there are those of us who have huge support networks and those of us who can get access to really high quality care. And then there's those of us who can't for whatever reason. Do you think that we are can we do more in clinical settings or in research settings to help identify all of those barriers for people and advocate for change? Or are there examples of groups who are doing it really well, to help make sure that we're identifying and overcoming obstacles to care?
Yeah, I think one of the things that we talk about the most is like access, right? Do patients have access to adequate screening? And so that's been one of the big pushes through a lot of organizations, including ours, to provide screening mammograms to folks in the community. We partner with community organizations, sororities, et cetera, to bring the mammograms to the patients rather than the patients having to come to the hospital. And so I think it's like things like those that help close that gap a little bit. And then in terms of, what was the other thing you asked me about?
Are there exemplar? Are there places who are doing it really well? Who are, is there equity in breast cancer access, treatment access somewhere? I don't know of anyone who's got it perfect.
Yeah, I don't know of anywhere that's got it perfect, but I think creating some of that equity has to do with a lot of personnel, right? There's a lot of people on the ground, folks who are making clinic appointments, folks who are calling patients to follow up, folks who are navigating, in addition to just the doctors, right? So you see the doctor for half an hour, 45 minutes, and you leave inundated with all this information. And then you're like, oh, but then what? And having some folks along the way that can kind of patient advocates, people who have been through things that you've been through, all of those things, I think help create that equity that we're looking for.
Do we have patient advocates at Brainerd MCW?
So we do have patient advocates. We also have new patient coordinators, which help patients kind of make sure they've got all the things they need before they come to their appointment. So they fill out an intake form beforehand. If they perhaps got their workup somewhere else, they make sure we have all the images and all that kind of stuff, which can really be labor intensive for patients and difficult to navigate. So that takes kind of one extra layer of work off of it for them. And then I know there are also various survivors and survivorship groups through here that patients are able to get involved in, which I think helps the process as well.
Hmm, wonderful. I am curious. So we started with, okay, internally in hospital and research settings, what can we be doing? Are there things in community settings that can be done to improve breast cancer outcomes? If a community is feeling really empowered to make change, are there things that they should start by doing, efforts that they should participate in? How can community members do more?
Yeah, I think community members can do more by using their their trust and using their power and word of mouth to let folks know their own personal experiences with this, and to encourage people and educate people that screening is a good thing, to help build trust in our healthcare system, that we have your best interest at heart. We want to take care of you. We look forward to taking care of you. And I think many of those community networks, whether it's churches or friend groups or what have you, that conversation with someone that says, yeah, I've been to Freighter and MCW and I did this, that, and the other, and I went through, got my mammogram and it was easy and it was this and that, goes such a long way. Even if I'm a physician and I say like, you should get screened, I probably carry less weight, than that community friend that already has that trust built in. So I would say encourage each other to get screened, be advocates for one another, and say, hey, if you're afraid to go alone, I'll go with you. And I think that using that community is really going to help us a lot.
Wonderful. I love that. I love it because it is scary. It's scary. I mean, going to the doctor for a regular checkup is scary, let alone something like this. So I think that network of support, both with, community health workers and patient advocates, and then social support. I mean, that's kind of the theme that I'm seeing, is that we can do more, if we're building strong support networks, for people, to improve breast cancer outcomes. I'm gonna segue a little bit because I am so impressed with your career and the things that you've accomplished, and I want to know where you're going. What's the goal? What is the 10-year, 15-year? Where is your career headed, in this field?
Yeah, well, I mean, I first and foremost really love taking care of patients. I think that's what gets a lot of us surgeons, doctors, into medicine to begin with. But I think more importantly for me in the big picture is being able to impact change, through research, through advocacy, through building community. I've only been here a short period of time, but I've met some people who are very, very passionate about breast cancer care in the community. and are really out here doing the work. Like I'm wildly impressed. And so I hope that I can only be, an addition to those things and to really help get involved, to be able to take care of patients in the hospital, but also to be able to understand why people make the decisions that they make, and how that informs our research and how we then translate our research back to the bedside to say, okay, we found this out, we know this works, we know this doesn't work, and now we're going to implement change based on those things. And sometimes it feels like a monumentous task, but I'm encouraged, particularly being here because there are so many people and so many resources all working toward the same goal. And so that makes it feel really tangible. And I'm excited to see what happens.
We are very excited to have you. I didn't even try to hide my excitement when I greeted you for the first time. But I did share, and I hope that the Milwaukee community, Southeastern Wisconsin community members who are listening do join me in welcoming you and being so excited that you're here on our campus and within our community. I think you will be so inspired by all of the assets that are in the area and all the opportunities to accomplish all the things that you talked about. There's so many wonderful assets here. So welcome. There's the form. I should have started with that welcome to our community.
Thank you. Thank
Yeah.
you.
So fortunate to have you, and we hope you stay for a long time. I want to just kind of ask a big picture question. So if money were no object, we didn't have to worry about resources, anything is possible, what would be the first things that you would do to improve breast cancer risk reduction, detection, treatment, survivorship? Where would you roll up your sleeves and really get working?
Yeah, that's like making my eyes twinkle. Money is no object.
Right?
Wow, okay. Um, so I think some of the things that come to mind initially for me is trying to make the process for patients easier. And when I say the process, I don't just mean like diagnosis, right? That's one part of it. But let's say now you've gone through your surgery and now you're getting radiation and you have to come to radiation every day for a week or every day for 2 weeks or however long. That can be such a burden to find someone to drive you, or to say, hey, I had to take off work for this week, or to say I need someone else, here, that contribute to all these other factors. And so my big thoughts are around making things like that easier. So if that means we have, a fleet of buses who go to various areas and pick up patients and say, okay, you're on the Tuesday, Thursday plan, so we're picking you up Tuesday, Thursday, and that eliminates that piece of it. Or to have some sort of, financial incentive or financial assistance for patients. So many patients face financial barriers and toxicity in getting their cancer treatment. And so you're already fighting for your life, but now you're worried because you don't know if you can pay your bills. So if money's no object, I'm handing it out left and right. Additionally, like having more, like we talked about, kind of boots on the ground in the hospital in terms of more patient navigators, more patient advocates, because there's always a limited supply of those things, right? That we can only do so much of what we have. But I would beef all those things up to just be able to spread the wealth a little bit more. So those are the things that I think about. Of course, I'm building a huge lab, I'm getting all the cool toys and stuff, but the things that are most important to me, I think, and what I hear patients talking about more often are just like, it's hard to park. Everybody gets to park for free. You know what I mean? Like off the top, like that's one less thing. So thinking about things like that, if I had all the money to give, I would just be giving it away.
I love it. And I think I share that. I find it mortifying that when someone shares their story about their journey, that there's so often a discussion of having to advocate for yourself to an employer, or having to battle an insurance issue. And it's just like, whoa, that should not be your focus. Your focus should not be bus routes and bus schedules. Your focus should be getting access to the very best care. So I'm with you. Let's get the checks and hand them out.
Right.
Absolutely with you. I want to turn back to the chat. There is a comment here that says, I was diagnosed with invasive lobular carcinoma in August of 2021. I have read from different resources that since ILC is so difficult to see on mammograms, that MRI or ultrasound should be used for further surveillance imaging. What are your thoughts?
So yeah, lobular cancer, or LCIS as she was describing it, excuse me, or invasive lobular cancer, can be what we call mammographically occult. So that means on a regular mammogram, we can't see it. So we certainly do use ultrasound, we use MRI and all the things at our disposal to try to make sure that we can see those things. Now, if you've undergone surgery already and your cancer is removed, then you don't necessarily need to have MRIs going forward. Just because you've had a lobular cancer once doesn't mean that you'll have a lobular cancer again. So, in some ways, after you have your surgery and your cancer is removed, the clock is reset, so to speak. And so you would go back to getting mammographic imaging. However, your treatment team is going to keep in mind, like, hey, we know that she had a lobular cancer one time. And so they're going to have a really low threshold if something comes back on your mammogram that doesn't look quite right, or you feel a mass or something like that, a low threshold to really investigate that further. But no, you don't necessarily need routine MRI screening just because you've had a lobular cancer in the past.
Wonderful. And to that person, wishing you the very best on your treatment journey. Um, all right, shifting back, I want to know who are your heroes in breast cancer care, research, general community? Who are you looking up to that's improving breast cancer outcomes?
Yeah, I feel really blessed. I've had so many amazing like mentors and people who, I've learned about through research and through just being in this field. And so there's so many to name. But when I think about it, I think about like the person who encouraged me to even go into breast surgery, and her name is Monet Bowling. She works in Indiana. And to me, I was just like so impressed with her because she was a breast surgeon. She was a Black woman. She was, providing excellent care for her patients. So in my mind, she's definitely one of my heroes. When I think about the research sphere, there's like I said, so many people. But Lisa Newman, she works in New York. Kelly Hunt, Suzanne Klimberg. Like I'm saying all these names, these are people who have either innovated in surgical technologies or have done research where, it's really changed the game, like really changed the way we treat patients. And it's gone truly from research to our clinical practice. So, and then in the community, especially here, like I said, I've met a few different people, the Sisters Network, this YWCA collaborative. These are things that I really hadn't heard of before I got here. And there are so many different groups. So, like I said, it's hard to name them all, but I'm really constantly in awe at how people keep up with breast cancer, how it's changing, surgical innovation, research, and then again, all the people involved in the community who are really on the ground, like fighting every day for this and making sure that people are getting the access that they need and providing those resources.
Absolutely. Yeah, absolutely. And I didn't mean to put you on the spot with trying to name every that could, well, who did I forget? Who did I forget?
I know if I
Um,
didn't say your name, I still heart you.
no, absolutely. But I think again, the point that is emerging for me as we keep talking is just these networks, these groups of people, these immense I want to say village, like these villages of people who support patients, who support those of us who do research, those of us who provide clinical care and do research. But yeah, that it's not just one or two of us in the field by ourselves, but really strong communities that are helping to improve outcomes. That's my impression.
No, you're exactly right. And I love the concept of the village because breast cancer care in and of itself is a village. Like, I cannot treat breast cancer in a vacuum by myself. Like, yes, I'm a surgeon, but I need my medical oncologist. I need my radiation oncologist. I need all the support staff that allow patients to have a well rounded treatment. Like, you just can't do it by yourself. So that village has to be there.
Well, we talked about screening, we talked about being a village, we talked about support. So there's everybody listening, can probably think of somebody, a family member, a loved one, who has breasts, and male or female, we all genders, we can get breast cancer. How do you broach this topic? If you want to ask somebody you care about, are you up to date on your screening? Is that invasive? Is that, breaching privacy? How do you talk to that person or those people who matter to you? Any recommendations for having a conversation about screening with the people we care about the most?
Yeah, I think this is so important because I think people do sometimes think, oh, well, that's not my business. You assume, oh, they know they're supposed to be getting a mammogram or they know that this or that, but they may not. And so I would encourage folks to, your family member better than anyone else, right? So you kind of know what kind of person they are, how they react to certain things, what approaches work best for them. But I would really encourage you to bring it up. For example, I have a million cousins, like literally a million. And so in our family group chat, I'm always like, okay, I know y'all are over 40. Have you gotten your mammogram? And if not, why not? And if you're confused or have a question, let me know. And I realize folks are going to say, "Well, you're a doctor." I know that, but you can do the same thing. And if it's easier in a text format, that's fine. Or if everybody has that one family member who's a little more outspoken than everyone else, get them, recruit them and say, "Hey, I want to make sure everybody's doing what they need to do. Like, can you ask Auntie so and so, or have you talked to your mom? Is she getting screened?" We don't have room or time for delayed diagnosis because we're afraid to have the conversation. It's too important. It's too important. And if they get mad at you, they'll be okay. They'll get over it.
Does anyone
Especially
get mad at you? Have you gotten in trouble?
they don't get mad at me. They're just kind of like, "Oh, here she goes," like here she comes again. And I don't care. And I persist because it's too important. And hopefully they'll see that really what you're doing is coming from a place of love. So yes, ask. It's not intrusive. If they don't like it, they can say no or not answer you, but you've done your part by asking.
I like to poke fun at it a little when I get the complaints from the family of just, oh, it must be so hard that I love you so much and that I want to keep you around. That must be really,
Exactly.
you should tell your friends how hard it is for you that you're so loved.
Yeah.
There's a question in the chat that goes along with this line of questions. So I want to get to it and ask, how do you encourage a family member that's hesitant to get a mammogram because of radiation exposure?
Oh, yeah, I would let them know that the amount of radiation exposure is actually pretty low. And it's hard to quantify. I know if you say low, well, how low is low? Um, but it's not, it's no more than if you were to get like a chest x-ray or some other, x-ray. In the time that you're actually under the x-ray machine, isn't really that long. So I would let them know that the amount of radiation exposure that they're getting is minimal. It is safe. The amount of rigor and checkpoints and this or that hospitals have to even do imaging is crazy. And so if it wasn't safe for you, I promise you they would not allow it. So I've just encouraged them to say it's very minimal. Invite them to come with you when you get your mammogram so they can see the process and hopefully build some trust from there.
Yeah, and I appreciate that question very much. So thank you for that participant. I've heard that as well. I've heard people say, "Well, don't the mammograms themselves, can't that cause breast cancer?" So having that reassurance that it's low, a low exposure to radiation is so important. Are there other common, you said you get in the group chat, you get people talking, and you said, I believe you said, you ask, if not, why not? Are there other common reasons that your family members might put forward about why they're not getting screened?
Yeah. Some people feel like, I'm young, I'm healthy, there's nothing wrong with me. Like, I don't feel bad. Like, why would I go to the doctor? And so this is not only a plug for screening and mammogram, but for seeing your family physician. You don't only have to go to the doctor when you feel bad. You can just get regular maintenance. You don't only take your car to the shop when it's falling apart. You go get an oil change from time to time, make sure things are running appropriately. And so I would encourage us to do the same with ourselves. Just because you're young and healthy doesn't mean you don't need to be screened or checked out. The other one that I've heard fairly often is that, if you do have cancer and you go to surgery for cancer, that when you have surgery for cancer, that we're cutting directly into the tumor and then we're spraying cancer and tumor all about. And this one in particularly, I like to kind of debunk because if I'm doing my job as your surgeon, I don't see your cancer. I don't physically see it. I don't cut directly through it. And honestly, even if I did, it's still not showering, cancer all over your body. But it's really not a thing where we are physically looking at your tumor open, cut through the middle, or anything like that.
Absolutely. Yeah. And that's news to me. I don't know what it's like. Maybe I can shadow you someday.
Yeah, yeah,
I've
yeah,
never
sure.
seen this.
No, that'd be
Um,
great.
I want to give a quick, there's 5 minutes left of our conversation. So if anybody is in the chat with your fingers over the keyboard, wondering if your question is good enough for this forum. I'm encouraging you, get in there. We've got a few more minutes to go. What I want to go back to though, is because I'm coming at everyone from Puerto Rico from the SACNIS conference, which is about including more or increasing the representation of underrepresented populations in medicine. And you said something earlier about having a mentor who is a Black woman. Can you comment at all about representation in medicine? And do you feel comfortable? I care about it because that's why I'm here right now. But why is it important that our physician and research workforces represent all the communities that they serve?
Yeah, I think having, kind of concordant mentors helps in many ways because it sounds kind of cliche, but if you see it, you can believe it. I saw a woman who looked like me and was like, okay, I can do that, and it kind of made it very tangible and very real. And I think that it's important for our workforce to reflect the population that we serve. So if only 2% of, surgeons are African American, but the population is 12 or 13% African American, then you can kind of see where we haven't really made balance. So, I mean, I think that's something that's super important. And I think it's even more important that we focus on, recruiting physicians of diverse backgrounds, but also then making sure that that inclusivity piece is really important and making sure that there's support and there's a network in order for those folks to really thrive and feel included in the whole system. So I definitely think all that stuff is important. I feel very, very grateful. I'm very cognizant of the fact that there's no way that I get to where I am without standing on the shoulders of those that come before me, and who have paved ways for me and sponsored me and mentored me. And so it's very important to me that I do the same. And so every chance I get, I'm at high school or I'm doing this or doing that to be the person that somebody sees and says, hey, she looks like me and I can do that.
Absolutely. Absolutely. And okay. All right. All right. How do you find time? So you're doing outreach, you are doing research, you're building a thriving research program, you are a wonderful physician to your patients. So how are you doing this? That's a lot.
Well, I will say that residency trains you to uh, be good at time management. And so then when you get to be an attending or, a staff physician, you're almost kind of like, oh, wait, I have a little time and let me start carving out these little blocks of time for all the things that I want to do. Um, and so, I mean, that's kind of how I approach it. For sure, I don't get to do all the things I want to do, but, um, I prioritize what's important to me.
And it's very evident that good care and community is so very important to you. You are new-ish. I forget, when did you come to Milwaukee? When was your arrival?
I moved to Milwaukee in August, so I
Okay.
am very new.
Now, I wanted to ask you your favorite things about Milwaukee, but there is an important question in the chat, so we'll come back to it if we have time, because I want to hear where you've been and haven't been yet. This question is important, and I'm really glad that someone was brave enough to put it in the chat. This person wrote, young Black women are being diagnosed with late stage and aggressive cancers. Does the ambiguity of breast cancer risk messaging contribute to the lack of early screening opportunities that are provided through policy?
I think so. I think we hear sort of blanket statement ideas about risk, but I think it's important to note, and I appreciate you bringing this up in this question, that there are some subsets of the population who are going to be at higher risk for different times. So, for example, before when they were saying, oh, you can get your mammogram at 45, a lot of us as physicians were saying, well, no, because, Black women in particular, they need to get their mammograms at 40 because they present earlier, they present with more aggressive disease, and it really is about the biology of the tumors, which don't get me down a rabbit hole talking about the biology, but I agree with you. I think that sometimes there is some mixed messaging because the messaging is for the majority, right? And we don't always all fit into um, that group. And so I think you bring up a very important point. And I think it's even more important for young Black women to sort of arm themselves and advocate for themselves and ask your physician, when am I supposed to get screened? Do you think it's important for me to get screened earlier? My mom had breast cancer, my aunt had breast cancer. If this is something that you're concerned about, by all means, please bring it up with your physicians.
Absolutely. Yeah, I couldn't go down a rabbit hole talking to you about cheese curds with a question like that in the chat.
No, no,
But
no, I understand.
yeah, but we are so grateful to have you, your expertise, your passion in at Freighter and MCW. So excited to see the great things that happen here in the community in partnership with you. I want to thank you for joining us today. And I know we had a couple little technical glitches with connections. Thank you for rolling with that. And we really do appreciate you taking the time to talk to us about this important topic.
Of course. Thank you so much for having me. This was a lot of fun. I was so nervous, and I'm glad that it turned out so well.
I was nervous too. If we didn't get to your questions, or if you if you didn't have, if you're still thinking, sometimes you gotta think, or if you watch this later, please feel free to drop an email to conversations@mcw.edu. And I hope you all join us next month for a virtual coffee break and a conversation with a scientist.